Oh, good morning, everyone, and welcome back to our first session of 24 Hours of Rare Industry Day. We're so excited to have this panel put together. We're going to be talking about big data with a focus on registries and its impact on health care with the IT slant. Joining us today on this panel, and we have Allison Heath, who's from CHOP. We have Terry Jo Bichell, who is from Combined Brain. And then from India, we are so privileged to have Mr. Prasanna Shirol. And we hope that Mr. Craig Martin will be joining us from the Global Gene to talk about RareX. But folks, I'm so thrilled and privileged. It's an honor to have you sitting on this panel and to be able to talk about your registries and what is going on in your part of the world, and what your hope, your goal is for the data collections you're doing with registries to help the rare disease community. I think to start off with, I'm going to have ask that each of you kind of go around, introduce yourself a little bit more in depth. Tell us a little bit about the registry that you have that's going. Allison, I'd like to start with you. Welcome to the panel, and thank you so much for participating today.
Thank you so much. It's such a pleasure to be here, and I think this is such a great event that you're putting on for rare diseases. So I'm Allison Heath. My background actually is in computer science, and really started out doing a lot of supercomputing and other things, and got brought into this world really by the advent of large-scale human genomics, and trying to handle that and manage that both securely while also making it available to a number of researchers. So I'm currently at the Children's Hospital of Philadelphia, where I've been for the last, I guess, almost 5 years now, and have been one of the PIs for a project called Gabriella Miller Kids First Data Resource Center. So this is a project that's funded by the NIH. Gabriella Miller, if you're not aware of her story, I encourage you to go look her up. She was a very strong advocate at 9 years old towards Congress of really being able to fund research in pediatrics. And the bill was passed that allocated previously funds that weren't used for the presidential campaigns towards pediatric research. And really the focus was on what aren't we studying well. And so what they decided to do was really focus on generating whole genomics data across a very wide swath of pediatric structural birth defects as well as pediatric cancer, really with the idea that, you know, when you first hear that, you kind of say, why do you study all these different diseases together? But really understanding that the genetic pathways of development, of growth, and other things are impacted kind of across here. And towards the point of being rare, sometimes there's really unexpected connections between different issues in cancer to certain birth defects because they might actually be affecting the same biological pathways. And so the Kids First Data Resource Center came out of that program to manage the different data sets to try to create a cloud-based platform that researchers, not just in the US, but across the world can come in and look at this data. So it's a little different. You know, we don't really use the term registry, but I think in a lot of ways what it is, you know, a research study that patients are consenting to be part of, and the data is being combined and provided out to the community. And so we've really thought a lot about the different, I think we call it the data use continuum of how people want to use these different data types. So there's the very raw, you know, your computational bioinformatician, all the way up to, I really just want to understand, you know, high level, what's going on with the disease, what I might want to understand clinically. I think that's actually a much tougher problem, but maybe that's my bias from computer science, thinking that, you know, looking at the bits and bytes are the easier problem. But really, how do we take a lot of this complex data as people understand those unexpected connections, provide visuals, provide tools, and I think, you know, ultimately really connect back to the patients, clinicians themselves to better understand these different diseases. And I think also in the pediatrics world, you know, we have a very strong mandate to interoperate and connect to other platforms as well. You know, I think traditionally, you know, people kind of think of it as, you know, kind of being, you know, a little bit siloed, but, you know, the truth is, you know, kids grow up, right? And we have to connect to different adult disorders. We have to understand kind of across the lifespan what's happening with these different diseases. And that's presented some, I think, really new and interesting challenges for different registries, data resources of how do you understand what happens, longer term? It's one thing to kind of have one point in time, collect information, understand kind of a landscape analysis. But if we really want to make impact, how do we take these kind of data resources and registries to there? And I guess the last thing that I'd say that we've really been focusing on is how do we do this in a little bit more real time? I think this is a huge challenge, but everyone who decides to participate, how do we learn from that information? How do we feed that back into the system? And there's always important trade-offs there, I think, about data quality and spending time to make sure you have good data, but also not holding on to it for too long so that other people can look at it and improve that quality as well. So these are some of the things that we've been thinking as part of Kids First, and really excited to hear about the other registries and data resources out there that can help support this really important work.
Allison, thank you so much. What a great initiative and project. Terry Jo, let's hear about the Combined Brain.
Okay, so I am Terry Jo Bichell. I'm the founder of this organization called Combined Brain, which I'll tell you about in just a second. But first, I want to tell you a little bit about how I got into this whole thing. I have a big family of 5 children, and my youngest child was diagnosed with Angelman syndrome. And that was more than 20 years ago. Actually, it was 21 years ago. He's 22 now. And at that time, there were no clinical trials for his syndrome at all. And we were, my husband was a surgeon, and I was a public health nurse midwife. So I was used to working on vital statistics data and on research on midwifery. My husband was used to working in surgery. And when our son was diagnosed, and we found that not only was there no treatment in the works whatsoever, there was also no information really about the natural history of the disease. We didn't even know what people with my son's disease would die from. We didn't know anything. I mean, it was really hard to predict what his life would be like, what our life would be like. Every bit of information was just gathered from case reports, from individual doctors having seen a whole bunch of kids. And in fact, a few doctors around the world who had really seen more kids than some of the other ones and had written up those papers. So that was really the only thing in the literature. And so I switched over to clinical research and working on clinical trials, trying to work with the scientists and the clinicians to get whatever they were doing in the bench that was low risk into clinical trials. And so we did that. We helped with some of the best teams in the world, and we got some clinical trials going, and none of them worked. And one of the things we found when we were busy getting these clinical trials going was that we really didn't have the natural history. We really didn't know enough about the children to be able to even tell if the drugs were working or not. So when we did the clinical trials, even if the drug helped, we might not really have known if the effect was subtle. And for a child with a neurodevelopmental disorder, you'll take a subtle improvement, even a small improvement in a small change in the kid's clinical status can actually really impact life and really make things better for the child and for the family. So we ended up starting a natural history trial, and this, I was just part of a big team, but we launched a natural history trial for Angelman syndrome. It was funded by the NIH, and that started to gather data. And that data started to tease apart if which mutation might be more severe. And if you had a certain mutation, could you actually have a seizure-free life? Whereas if you had most of the other mutations, was it very, very, very likely that you would have seizures? So we started to pull apart how the genotype and the phenotype followed each other. So that gave a lot of information to me, to all the other researchers, and to all the other clinical trials. At that point, I was approaching middle age. My son was approaching junior high, and I was tired of how long it was taking to get any kind of a treatment to work in Angelman syndrome. So I went back to school and I got a PhD in neuroscience as a middle-aged lady, and worked really hard on what I thought was a great idea for a high-throughput screen to be able to repurpose drugs for Angelman syndrome. And lucky for me, somebody else who had more experience and a lot more resources actually did a great high-throughput screen and came up with a drug that could actually really, really help Angelman syndrome. And so by the time I graduated with my PhD, what we found out at that point was that we had a drug that worked, but we didn't know enough still about Angelman syndrome natural history and Angelman syndrome outcomes to really be able to measure if that drug was working or not. So I ended up leading an organization called the Angelman Biomarkers and Outcome Measures Alliance, the ABA. And that organization pulled together 140 academics, about 40 pharmaceutical firms, and it was paid for by 2 foundations who joined together to pay for the expenses. And we all worked together to look for biomarkers and outcome measures. Most of the information that we needed to come up with those biomarkers and outcome measures had to come from registries and from natural history studies. So right now, there are a lot of clinical trials going for Angelman syndrome. Some of them are potentially life-changing, life-altering treatments. So after a couple of years of that, I formed Combined Brain, which is an organization of 25 neurological disorders. All are rare, genetic, severe neurological disorders, and all of them are very similar to Angelman syndrome, so that we can try to use the experience that we gleaned in Angelman syndrome to get all 25 of these disorders through clinical trials faster. And I promise I'm almost done. But the most important thing that we're doing as part of Combined Brain is trying to make sure that every one of our disorders does have a registry, is collecting natural history data. And then what we are working on now is trying to make all that data across those 25 disorders comparable. We want to be able to look across disorders and see which symptoms are the same across disorders, which outcome measures can be used across disorders, which biomarkers can be used across disorders. So at Combined Brain, we've been working really hard on coming up with ways to compare registries in natural history trials. So to me, this is one of the absolute most important topics that you could bring up for any rare disease. Thank you so much for doing this and for inviting me today.
Thank you, Terry Jo. Craig, didn't get the chance to introduce you. I introduced you, but you weren't on. We're so happy to have you joining us. Craig is currently with Global Gene, but is also the co-founder of a registry called RareX. So, Craig, tell us a little bit about the RareX registry, what your goal is, in about 5 to 7 minutes, and if you can keep it to that. I know that we give entire presentations on these things, but it's so good to have you here.
Yeah, thanks, and really appreciate the other panelists and what they're presenting and what they're doing. So RareX actually originated out of Global Genes. We had a brainstorm a few years back and sat around in a room and thought, what's holding us back in terms of progress in rare disease? And there were a number of people from our board, our medical and scientific advisory board, and others in that room. And the answer we all sort of landed on was data. The fact that there is no good way of really accessing data across diseases, and oftentimes even within diseases. And the data sets that are out there are inconsistent. Oftentimes patient communities may have a registry or what they look at as a registry, but it may not have the information in it or structured in the right way to be really useful to researchers. So we set about thinking of ways in which we could change that dynamic, and that's where RareX emerged. One of the folks around the table with us that day was Anthony Philippakis from the Broad Institute. The Broad, as some of you may know, is an organization that's launched a number of large-scale public data, genomic and other information data sharing initiatives, like all of us in the US with NIH and Count Me In, but also some projects in the UK and elsewhere around genomic data sharing. And the Broad was generous enough to bring to the table the technology stack that they were using for those initiatives as a basis for establishing RareX as a platform. The goal of which was to allow for a place where organizations who maybe were earlier on in their data sharing journey would be able to develop a registry or a natural history study or a data set that might be useful to them in their disease on the platform for free. And to help ensure that the data and the way it was structured was designed from the get-go to help assure that whatever data it was they were collecting would ultimately be useful and productive for research or other purposes. In addition to that, the Broad has a platform for data analysis. So Terry Jo, the issue that you were talking about where you might have 5 or 6 different registries or data sets or natural history studies. Maybe they're spanning lysosomal storage diseases or some other condition area where there may be commonalities in that data that it'd be important for researchers to understand, but without access to it, they'd never find it. So part of the RareX platform is a federated data sharing and analysis component that creates the opportunity to do just what you described, to really help enable researchers around the world to look at data sets where organizations may not want to give up control of that data set. So that's another issue we don't talk a lot about, but it's a factor. But they would be willing, maybe because their community is pushing them to do so, but to provide that data set in this analytics platform alongside other data sets to create the opportunity for it to be more visible and more easily queried by researchers around the globe. So that's really, in a nutshell, what RareX is designed to do. I think there's an understanding that no one solution is going to solve every problem across the landscape, but our goal is to really, for those institutions that are and organizations that are in the right place, to either want to start to collect data or that want to share it, that they have an opportunity to do so.
Thanks, Craig. I really appreciate your input. Mr. Prasanna from India, talk to us a little about what's going on with some of the India registries.
Okay. Thank you, Jeff, for this opportunity to discuss on patient registry. Just a brief introduction about myself. I'm Prasanna, co-founder and executive director of ORDI, Organization for Rare Disease India. I'm also a father of Bombay patient who happens to be the first patient in India. Now she's 22 years old, and my journey with her in terms of diagnosis for 7 years and 13 years being on ventilator, managing the entire medical episodes and life, and also in absence of healthcare policies in India way back in 2007-8, started my journey in rare disease advocacy with Pompey Foundation, then Lysosomal Storage Disorder Support Society, and later in 2013 when realized that it is not just about 30-40 diseases, but it's about 7,000 diseases. And India did not have one parent organization representing all the 7,000 plus rare diseases. Based on the idea of HoR, NORD, various organizations, ORDI came into picture. And last 6 years we are into patient advocacy, patient services, awareness, and also clinical trials and research and development wherever possible. So some of our work includes, we have started India's first rare disease helpline. Then for awareness, we have a unique program called Race for 7, where being conducted in almost 11 cities. And this year in 2021, we just concluded 6th edition of Race for 7, where people from 200 cities participated. And we are the one who responsible for bringing the rare diseases discussion from 4 walls of the doctor or a family house to a public health discussion. We do not have a rare disease policy yet, and it's expected to announce by 31st of March this year, this month rather. That is the scenario. When coming to patient registry, there are no standard patient registry from the government of India for any diseases. This is all disease-specific registry. There is one agency called ICMR, Indian Council for Medical Researches. They manages most of the registries created or managed by government side. And this is basically on a need-based, basically where numbers are important for public health planning. And also, the ICMR has a huge network in India because 28 states, provinces, what you call, and also union territories, health is a state subject. So there is a complication between the central government and the state government. In some state, wherever the disease burden is very high, they have their own registry, but mostly it is the ICMR who manages this registry, and they're all cancer registry, hemophilia, major diseases. Apart from this, there are certain government institutions who also have their own registry. Okay, then private hospitals and doctors plays an important role because India healthcare, 60 to 80% is in the private hospital because government is still at the primary healthcare level and they are not into specialized or super specialized diseases. And some of the hospitals and doctors, of course, when I say doctors, these are the government funded institutions, but they have their own registry. When it comes to rare diseases, it is always, only in case of hemophilia, there is a patient registry managed by parents from a longer period. And very recently, some of people like cancer registry is there in collaboration with the government and other things are online. But when it comes to rare diseases, it is always the Indian patient database being uploaded in a global patient registry, either through individual patient registry who are connected to a global patient support group. India-based disease-specific support group who gives in data in collaboration with their parent company. Those are the one. Second, in like for example LSD, it is a LSD registry maintained by the company Sanofi Genzyme, and all the data basically wherever they give compensate access program, those patient data is being given to the global registry of the pharma company. So overall, if you look at it, there is no patient registry, a standard registry where government plans either for a normal diseases or for a rare disease. But very important is in 2017, ICMR started a rare disease patient registry. Now it is almost 4 years. Still, we have not seen any data being fed into it. They are still in the planning stage. They have appointed some 26 nodal officers where data entry is taking place, because you also have to see India is not like any other country. Our one city is equal to one country of either Europe or sometime US. So it is always the numbers, and government planning always takes 2 to 3 years on an average, which is historically to manage such a 1.3 billion population. I think we have to live with it. But there is a registry. I think next 1 year there will be some good hope from ICMR on rare disease front. And once the good news is that most of the geneticists have a huge registry. For example, if I have to talk about one state, Karnataka, where I belongs to, one doctor has a registry of 28,000 families registry from last 15 years. That means you can imagine the numbers. So once the government is ready, the data entry points are ready. Overnight, the data can be fed into them, and it can play an important role in terms of rare disease, especially on this front. And also, government now talking about PPP model, especially after the COVID, private-public partnership. I think in going forward, that will be a next thing which government and private hospitals can join together, starting this some other disease-specific patient registry. And role of big data. Finally, I think India being one of the IT capital, Silicon cities, what they call twin cities, India and US. I think that is also playing an important role. But unfortunately, we still do not have any strict regulation when it comes to data. It is just started for the general data purposes, but when it comes to healthcare, still we are lagging behind. Once the clarity is there and once there is a planning on healthcare data, I think big data will take the leapfrog jump, and I think we can definitely change the scenario in rare disease. What I can say. Thank you.
Thank you, Mr. Prasanna. And thank you all for sharing what you did. Very different perspective coming from India than from the States. My first question to the panel, and this is going to seem maybe a little bit from a patient side of things. There are some patients that in communities that we talk with that go, I'm a little concerned about joining that registry because I'm not sure what's going to happen with my data. Are they going to take my data and sell it? I mean, obviously, everybody wants to participate for research and to be able to find answers to what's going on with themselves or their child. But how do you all, and Mr. Prasanna, this will probably be a little different from your side of thing, but Allison, how do you guys, do you have to address that with it? What do you tell patients if they come in and they go, or are you just going to take my data and sell it to somebody? I mean, and Craig, you talked about the data sharing agreements, which is awesome because we have to collaborate. I mean, and, Terry Jo, you talked about there are crossovers and we see it. I mean, we see it with our own daughter's, diagnoses. She's got 12 different things going on. And there are these crossovers that happen and to identify. But how do you all address that? Allison, what do you think?
So, I mean, I'm actually very curious to hear from the other panelists because, like I said, I think I'm more on the tech side, but I think Kids First has been a really interesting journey where we have a very strong kind of outreach arm and component of the team that works with many different patient foundations. We actually do a foundation highlight. And I've really appreciated actually getting to know the community a lot more. And I think it's a really delicate balance of, as a person, you're consenting to a fair bit of your data being brought into here. I think as a federal program, we're obviously not selling the data or using it for any of those purposes. But at the same time, we're talking about interoperating. We're talking about how do we engage with the right, pharma companies? Ultimately, you want to create new treatments. You want to create new drugs to help folks. And what's the right place there of how do you engage with that while also respecting kind of the original wishes? And we aren't there yet, but I often, as a technologist, dream of being able to have more of a patient-facing portal to see what studies are using my data, what researchers are looking at this. I think people really want that. It's actually, I think, a big challenge right now, but I think the technology and things are getting there. But we spent a lot of time, I think, having different discussions with both, teams at NIH, teams with the foundations of, okay, yeah, originally, you thought you were submitting your data for this very specific disease, and now someone has found that your disease actually links with this other disease that have similar genetic components. What is the right path forward there? Clearly, if you want to help that disease, combining it with this other disease study might provide more information and help move things forward. So I think we're in that world where we need to understand that. We need to also provide researchers a view of this. I think a lot of times, if you, like myself, was just a PhD in computer science, you're actually never, it's funny. I reflect back at how you didn't really think of it as patients or human data. You just kind of thought of it as data. So how do we also do the outreach on that side that people are really understanding, when I'm looking at this is really, I was standing at a doctor's office once, signing a piece of paper saying that my data is going to go here. And now you're at the other receiving side, really trying to help improve that. So these are some of the things I think I think we're thinking actively about. There's, I think, a really good debate. I think it's been great that NIH, I think, is engaged with the patient foundations much more closely to have these discussions. And then I'll also say something that I've observed, we have, really terrible pediatric cancers where the prognosis is 9 months. And I think that puts a very different perspective on the type of disease where you can, have good quality of life, but you still want to, understand it. And the pressure points that it puts on data sharing across those are very different. At the same time, I think in pediatric leukemias, we've had pretty good survivorship. And, originally it was maybe a poor prognosis, but now, people are living 20, 30 years later. And what does that mean for their data that their parents, provided when they were kids? So I don't know if I have a lot of answers right now, but I would like to kind of say, I think those discussions are happening very actively. And I think we're very interested in understanding how technology can support, people's original intents and, why you participate in these studies in the first place.
Absolutely. Terry Jo, what are your thoughts on this topic and with the patient, and what do you express to them?
Well, this is one of my favorite aspects of this topic. I have written an article about how privacy makes me sick. And I really think that when you are a person with a rare disease, privacy is one of the last things you need. That what you need is to use your data. It's powerful to get to a cure. And so whenever we turn in data for my son or data for me, just to help as a control, we are thrilled when it gets sold, when it gets used. I want every iota of my son's data and my data to be sold. I want it to be sold over and over and over again. I want everyone who possibly wants to look at it to look at it. Everybody who looks at it might have a bit of a piece of the puzzle, and that's a very important thing. I actually had Megan O'Boyle from RareX speak at a meeting a month ago or so, and one of the first things she said was how we go through a drive-in fast food place and we use our credit card. What we're doing is we're giving away our data. We're on Facebook, we're giving away our data. We're giving away our data every time we snap our fingers and call Alexa to go do something. And yet we're, for some strange reason, very afraid of giving away the data that could cure us. So for me, it's what I think is the most important thing is that the patient still has control over his own data or her own data, meaning that you can share it with whoever you want. I think that's very, very important. But I also think that it's important for rare disease patients to realize that letting their data be sold is empowering. So we at Combined Brain are try really hard, and it's all a work in progress. We're not there yet, but we try really hard to find ways for people to collect data every day as they're going about their business. Not just healthcare, but if their child falls down, write it down on your phone, on an app that goes into a piece of data. And every time that kid has a fall, that becomes a piece of data. And it's possible that when you aggregate all those data bits about falls themselves could become an endpoint for a clinical trial. So that's my soapbox.
Well, thank you for sharing that. Craig, I know that you guys have done a lot with federated databases and data sharing and stuff. Kind of give me your perspective on this that you would tell the patient with what was going on.
Yeah, I think, Terry Jo raised two really important points. One is not letting privacy and the regulation of privacy be a barrier to what patients want to have happen with their data. The other piece is about control. One of the things that we heard a lot about when we were starting up RareX was patient communities that had contributed in good faith a lot of data to a registry that they thought they controlled, but didn't. And then lo and behold, found when they needed to get access to that data or to use it or wanted to use it for other purposes, they couldn't. And so, the notion of whether you want to call it ownership or control is an important one. And so from the get-go, all of the organizations that are involved in RareX have to be committed to the idea that patients should control their data. And we spent a lot of time up front on data governance, which sounds kind of boring, but is important because having a process in place where patients can consistently consent to how their data can and should be used, and making it as accessible as possible, but within parameters that help ensure that they don't lose control of it. Meaning that if they want it back or they want it used for a distinct purpose, they have the opportunity to do that. And one of the benefits that came with the relationship with Broad is that they had developed what they called DUOS, which is a data use and oversight system that makes it easier to grant those permissions and then to track and find out, well, who's using my data and for what purpose, and to get reports on those kinds of things. Because you can imagine for an individual community, the burden that it places on them to have to take in individual requests for access to data, provide permission, check on whether that's, consistent with the criteria they have for data sharing. Whereas having an automated system helps you to do that at scale. So, for us, it was about at a foundational level saying the patients control their data. And some organizations, because the requirement for data stewardship can be intense. If a commercial entity wants to extract data from their data set, they may want to negotiate with that company, for example, that they should get some value back from that. And so they can go outside of the RareX system and do that. And our goal is not to get in the middle of that or to control all the data sets. It's to make sure that each organization and community that's contributing data has the opportunity to do the best thing that they can with that data. So I think that's one way you'll see we start to tackle that problem, is that instead of some random organization out there mining that data and maybe using it in ways that the community is unaware of, they control that interaction. And if there's a transaction that goes along with it, maybe they control that too. And in that way, ultimately, it's the patient community that is the beneficiary of what happens with their data. And if you think about things like cell and gene therapy, for example, where it's not just the research side of data, they may be tracking outcomes for 15, 20, 30 years as a community. And we need a way to support their continued involvement in doing that.
Thank you, Craig. Mr. Prasanna, I know that India is still developing the registries with that. You have a totally different, medical system with government and different things there. But what will you be telling, people who are coming to sign up for registries in India? What can you share with them about their data and who owns it and what's going to be happening with it? You're still muted, sir.
Yeah, sorry. Thanks for the question. Let me put it in this way. Awareness about data can be divided into 3 factors. First factor is, this is based on the education, whether it's a rich or a poor based. Because when it comes to poor or uneducated patients, they don't know anything. They just listen to the doctor. Okay, they will sign wherever they sign. One, because either it is being given at the government hospital or being given at the private hospital, but for a free of cost as a gesture from the doctor's side because of the economic condition of the family. So this class is unaware. They just do whatever doctor says. The second one is middle class is one who are 50-50. They are educated, they know something about data, something about privacy, they have seen Google, they are all IT people. Based on that, they at least ask you questions to the doctor, why should I give, and other thing. Then the third class is rich and educated. They are very, very choosy, and you may not get data so easily because they are influenced by many things, both education and also the confidentiality of the data, especially when it comes to rich, because of the genetic in nature. Then the second one is, it is emotional and relation. Here, it affects all the 3 classes. Because we treat doctor as God in our country, whatever doctor says, when there is a good relation, when they are emotionally connected with the doctor, they just sign the patient registry or any, consent, irrespective of their richness, irrespective of their education background, because that is the relation with the doctor. Then the third category is rare disease patients, families, and the patient support group. There, they take the decision as a group, either to submit the data to a patient registry or their own registry within India or outside. So this group is 50-50, and still it's a confused state because there is a lot of new news is coming. About the data, it's just around last 3, 4, or 5 years where it's being discussed more on a public forum regularly by many hospitals, doctors across India. So they are in the state. But the main worry to most of the educated people or educated patients is that if you look at it, India do not have any registry, as I told you. So last 10-20 years, data is going to the patient registry. What is happening to my data? Nobody knows. That is the question being asked, one. Second, if I give the data, when do I get back the return? Either in terms of a treatment to me or to somebody else. Because most of this data which is going to Europe, US, the drug is being developed there, including this patient data from India. And when the drug gets FDA approved, either it is very costly and inaccessible to the patient of India. So that is being raised very on a high note. I think, and also now some people know that data is being used for commercial use or misused by some pharma companies or some vested interest. There is a lot of awareness in last 3-4 years, and I can only say that we are all in a confused state in India on behalf of everyone. it's all a mixed reaction and opinion about data. Thank you.
Thank you, Mr. Prasanna. Oh, wow, what a spread across there. So we only have about 14, 15 minutes left. So the last thing I'm going to jump to is one of the last questions. And this is going to be an opinion from each of you as stakeholders, your different views, your different points. And with that, is it what do you see in the future of big data and collaboration in the rare disease community? And we've kind of touched on that. And we've kind of looked at some of the goals behind that, where we're talking about data collaboration, data sharing. But I would love to get your all's perspective, because each of you are kind of in a different place with some of these things. Allison, what do you see as the future for big data collaboration with rare disease?
Yeah, I think I hinted at this a little bit with my previous response, and it was great to hear the other perspectives. Just in the previous question, I was just reflecting on, we talk a lot about risk of harm, and I think there's a large risk of harm when we don't data share, and I think people forget that as well. I think maybe from my perspective, we focused a lot on the genomics, and Craig's mentioned a lot about what the Broad's efforts has done. And I think it really is, there's a lot of these good systems, good registries. I think interoperability is a big one. We're actually also working with Broad to have different capabilities to link with the different systems he highlighted. We have a platform called Cavatica, which we're trying to create new models, both nationally and internationally, to link this data. So we launched Cavatica Australia and have been working with folks there in terms of how do we do this analysis where some of this big data is hard to move, and how do we bring the compute to those locations, create the kind of more aggregation stats, the higher level data that can be more in a matrix format that often people ultimately want to use. So how do we get the right features? And I think those features feed into a lot of new techniques and algorithms. I think there's different aspects of machine learning, but in the rare, it's actually very hard because you need to have large numbers often to bring those techniques to bear. And so there's a big question of how do you have those techniques where maybe you have less numbers, but more information, more depth of information, more follow-up. I think that's going to be very important. So being able to combine those data to be able to really have new methods that focus on the fact that I'm not looking at diabetes. Like, I don't have this huge population that I can run these methods on. We're really trying to understand these different techniques. And it's kind of boring, but I feel like standards are increasingly important towards how do we bring this data together. We've been doing a lot of work with something coming out of the EHR community FHIR. Which is basically standards for how do we interchange health data. So if you look, for example, if you've ever done the Apple Health and you can connect to your own patient portal, there's actually, if you scroll all the way down, there's a little thing that says see the FHIR JSON. You can see the actual tech standards and how your data is formatted. I think really starting to push on those standards. I think the Office of the National Coordinator in the US has really mandated the 21st Century Cures Act. But I think what's important is that, a lot of that time it is geared towards the kind of common, how do we make sure that the different things we want to capture about rare diseases follow similar standards, can actually be incorporated and integrated there. And then I think the last part I'll say, we've had a real big focus on genomics. I think there's a lot of other data modalities that can be brought to bear. I think there's a lot of interesting things happening with wearables, with imaging, other new modern kind of molecular assays, proteomics, and we found very interesting things in some of the cancer space. So we've been able to find differentials in different brain tumors. There's a recent Cell paper that is actually already being turned into clinical trials for some of these very rare subtypes. So not just, I think, wide data, but also kind of the deep data, especially in the rare, is going to be important, and building the platforms that can interchange that, share that, make it discoverable towards different people. And then I think I talked a lot about how do we address some of these issues around patient data, being able to show people, your data is everywhere. Every pair of eyes that you want to looking at it, I think that'd be great. Or even sometimes, I think transparency into like my data is not being shared. I do want it to be shared there. I know your IRB said maybe there's some risk, but I don't view the risk and harm. How do I do that? Or the opposite. I've I feel like that researcher is doing something with my data that I don't want, or I don't think is appropriate. How do I bring that to bear? And I think those types of technologies and how do we kind of, not just create a giant data aggregation, but really feed it back to the patients is really important. So that was kind of a wide spectrum, and I think we have a lot of work to do, but I think we're in very exciting days where we're already starting to see the benefits of having these types of platforms. It's been really amazing in Kids First to start seeing people doing these cross-disease analysis and already finding different kind of benefits for diseases in unexpected ways. So being able to increase that like serendipity of, anyone who's been in kind of a research environment, you have to be like, some of my best ideas was just chatting over coffee with someone, and suddenly I realized that their mutation was the same that I was working on. And how do we do that at scale that to really address many of these different diseases?
Thank you, Allison. Terry Jo, what's your perspective on this big data and collaboration moving forward, during this time?
Well, first off, that was all really interesting what you just said, Allison. I'm dying to look into more of what you've just talked about that y'all have already been doing. But I'm going to focus my comment on a patient's own unique identifying number. There are a lot of different systems, European systems that are very cognizant of privacy, and American systems that are worried about big government. I don't know how it works in India, but one of the things that we've been trying to work hard on is a way for the patient to have a unique identifying number for health data that they can take anywhere, so that when we do a study, there would always be a section there where if the patient has a unique number, they can enter that in. And some countries don't like it that way, and so they might not accept it. This is a really complicated problem. There are also legal issues in some countries that actually prevent the use of a unique identifying number. So there are all kinds of systems. I know that RareX has been working on this, and we've had a lot of people weighing in. Some people even think blockchain is the way to go about it. Some people think that it's just that you collect the same background information on patients, so that there could be a central command that could actually identify if a patient has been in more than one study, so that you could unite that data. But we've been working on that problem, so that if I, Terry Jo Bichell, went into a study, then at the beginning of the study, I could say, this is my unique number, I want it entered into the data. And then at a later date, maybe I've even passed away, that study could be linked to another study because it has my unique number in it.
Excellent, thank you. You said something interesting there. I'm actually giving a presentation on blockchain and medical records next month. Technology has some great benefits, but there's also some great drawbacks from it too. There's no, I think Craig said this to it. There's no perfect solution out there right now with it, and they all have some unique perspective. Craig, real quick, what's your take on this?
Well, I think Allison and Terry Jo covered a lot of the really important points. Having common data standards, for example, as mundane as that might sound, really helps in terms of being able to share and make better use of data that's gathered from across different systems and different organizations. So I think that's an important point. I think the notion of a unique identifying number is also an important point, and the ability to make sure, because I do think ultimately it's going to be more of this federated data approach that's going to make it possible for us to gather and share and be able to analyze more information on a common platform, because everybody's not going to always collect their data on the same platform. So I think that's important. And I think it'll be interesting to get Prasanna's perspective on this, but the global nature of rare disease is also something that we're going to need to address. You know, there are countries where it's difficult for data to cross a border. And so research is increasingly global, especially in rare disease, and especially because patients are so scattered and the numbers are so small. Even to conduct a trial really requires global collaboration. So helping to ensure that there's more opportunity for data to come together cross-border, cross-region, I think is also going to be an important thing that we'll have to tackle moving forward.
Thank you, Craig. Mr. Prasanna, I know that India, kind of give us an idea of where you see with the stuff happening in India real quickly with the large data.
Yeah, I think it's too early to discuss about big data in India because of the any kind of a data availability in a public forum, either by government or a private, because it's still scattered around. But having said that, big data will definitely play an important role, given that a lot of undiagnosed patients are there in a country like India, and especially when we get digitalize all the healthcare information from the government, which is in the process. I think then we might get a lot of usefulness from the big data going forward. That's what I can say, because big data is playing a role in every sphere of activity. I'm sure it will play important activity in healthcare, and also especially for rare disease for India is what I can say.
Thank you all. What a great input from everybody. The perspectives you brought and the different systems that you're working with. Allison, thank you for coming and sharing, and the technical background that you have with it. And then, Terry Joe, you started this kind of your personal mission, and Craig, your passion for it, and RareX, and Prasanna, obviously, you have a great love and depth for your country and what's going on with the rare disease community there. And I want to say a shout out to Swapna. She put me in touch with you and for this event. Thank you all for participating in this. We're coming down to just a minute left with it. And I just wanted to say thank you to each of you. This has been amazing, and we'll give you access to the recording when it's available. But I just wanted to say from my heart to you, thank you so much for addressing these questions and being open and very straightforward with your feelings and your views and your opinions and what's happening out there, not just in the United States, but also in other places in the world. Thank you all so much, and hope you join other sessions of the 24 Hours of Rare today for industry. Thank you all.
Thank you, Jeff.